everyone. As a part of continuous cardiac education, our topic of discussion today is Physiological Assessment of Coronary Artery, FFR and IFR, by Dr. Gaurav Singh sir, who is Assistant Professor in the Cardiology Department at Unmicrc Hospital and having 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Good morning everyone. I am Dr. Gaurav Singh. I am a DOM cardiologist from Unmicrc Hospital, Ahmedabad. And today we are going to discuss about a very interesting imaging modality in ischemic heart disease, that is FFR. FFR stands for fractional flow reserve. Why we need FFR? Despite the excellent imaging provided by the coronary angiography and IVAS, there is a weak correlation between the luminal anatomy and coronary blood flow reserve, which makes such direct measurement of coronary flow physiology in the cath lab very valuable in evaluation of angiographically borderline lesion. So adoption of invasive coronary physiologic lesion assessment before PCI has become a routine in many cath lab, including ours. FFR has validated against non-invasive stress testing and found to be highly accurate. What is the rationale for in-lab coronary physiology assessment? So as you can see, these are coronary angiographic images, and in short it provides two-dimensional images of three-dimensional vascular lumen. So we can see in one image, it appears to be significant 75% lesion, but in another image the same lesion appears 20%. So basically these are the limitations of conventional angiography. So what are the all limitations of routine coronary angiography? The first one is it overestimates the stenosis. It cannot visually assess intermediate lesions, that is 40 to 70% narrowing, whether they are significant or not. It only visualizes only lumen and no data about the nature of the plaque or its pathology. It is just an anatomical map without any physiological information. It cannot visualize very small arterioles. It does not account for other geometric diameter length characteristics, like what is the absolute diameter, what is the length, where is the exit angle, where is the entrance, what is the eccentricity, and serial stenosis in one artery are very difficult to assess. So here comes the fractional flow reserve. Because of all these limitations, we need some imaging or some modality to assess the physiology, whether the lesion is significant or not. So what is the FFR? By definition, it is basically maximal achievable blood flow in stenotic coronary artery divided by maximum blood flow in the same artery without stenosis. And how we do it? FFR is basically mathematically it derives from distal coronary pressure measurement divided by proximal coronary pressure measurement during maximal hyperemia. So FFR is basically distal pressure to stenosis divided by proximal pressure to the stenosis during a stage of maximal hyperemia. That is FFR is equal to PD by PA. So you can see how the FFR is measured. FFR is basically stenotic perfusion pressure divided by normal perfusion pressure, that is PD by PA. So what are the advantages of FFR? FFR has a well-defined cutoff. So when you get a value of 0.75, it is invariably associated with significant myocardial ischemia, and it has a specificity of approximately 100% with a sensitivity of 88%. So stenosis with a FFR of more than 0.8 are almost never associated with exercise-induced ischemia, and we have a gray zone between 0.75 to 0.8. And FFR measurement correlates with the likelihood of ischemia. So when you get an FFR in a lesion where its value is more than 7.5, you can leave it because ischemia is very unlikely and it has a sensitivity of 88%. Whereas you have a FFR of less than 0.75, then ischemia is there, you need to tackle it, and it has got specificity of 100%. So you can see FFR accurately identifies lesion responsible for ischemia that in many cases either by angiography or intravascular ultrasound would not have been detected. So what are the unique characteristics of FFR? So FFR is not influenced by systemic hemodynamics in contrast to many other indices measured at cath lab, which are changeable to systemic hemodynamics, do not influence the value of FFR in a given coronary stenosis. In addition, FFR has been shown to be independent of gender, risk factor such as hypertension and diabetes. This is a very important point. FFR is not influenced by gender, race, any other risk factors like hypertension and diabetes. In normal epicardial coronary artery, there is virtually no decline in pressure at rest or during maximal hyperemia, and so PD by PA is equal to or very close to unity. So these characteristics contribute to accuracy of method and have helped to establish its role as a valuable tool to add in clinical decision making. So how we measure FFR? Measurement technique. So the measurement of coronary pressure is similar to performing a angioplasty. In that, a sensor guide wire is passed through the angioplasty guiding catheter with after anticoagulation. To minimize measurement variability caused by spasm, we give intracoronary nitroglycerin, which is a vasodilator, before the guide wire is advanced into the artery. So what types of wire are available for FFR measurement? There are basically two types of wire. One is from St. Jude and another is from Volcano. Both can be used as angioplasty guide wires with mechanical properties close to standard workhorse guide wires. So these are the sensor is basically located 30 mm from the tip in both wires at the junction between the radio opaque and radiolucent portion. So this is somehow what our FFR wire looks like. We got a sensor which is approximately 3 mm from the tip, and it is just at the junction between radio opaque and radiolucent portion. So before inserting the guide wire into the patient, the sensor wire and the guide wire catheter pressure signals are calibrated and set at a 0. Then the sensor wire is then introduced and positioned at the tip of the guiding catheter, where the guiding catheter and the pressure wire are equalized. Next, the wire is advanced down the vessel and across the stenosis or the most distal part of the coronary artery for assessment of serial lesion in case of diffuse disease. Then after the positioning of FFR wire, we have to give a pharmacological hyperemic stimulus. Most commonly we give adenosine, which is given by IV infusion or intracoronary bolus. The mean and phasic pressure signals are continuously recorded, and at the peak hyperemia, we measure the aortic pressure and distal and proximal coronary pressure. So this is how you do the FFR. FFR we all know is PD by PA. So after advancing the guide wire, the sensor is located 3 centimeter just proximal to the tip. We advance the guide wire in the more distal portion of the vessel or beyond the stenotic lesion. Then we give intracoronary or infusion adenosine to achieve the maximal hyperemia. Then we measure the pressure, and the FFR is PD by PA. So for hyperemia, we have already discussed that you most commonly use adenosine. So there are two ways to give adenosine, either by infusion or by intracoronary. Both are equivalent, and the dose usually is for right-sided system like RCA we give 40 to 50 microgram, and for left side system we give 100 to 200 microgram as an intravenous bolus. And this is the flow chart how you prepare the infusion dose or when you want to give adenosine by infusion. So basically take 8 ampule adenosine in 34 ml saline. Then according to body weight we run the infusion. Like for 48 kg it will be 350 ml per hour. So we both intracoronary adenosine and IV adenosine are the most commonly used hyperemic agent. Adenosine has the advantage that it has got a very short half-life with a return to basal flow within 30 to 60 seconds after completion of its infusion. Adenosine is started at an appropriate dose, that is we have already discussed, that is 40 to 60 microgram in right coronary system and 100 to 200 microgram in left coronary system by intravenous bolus. Rarely transient AV block can occur, so we need to prepare with atropine also. Two technologies are why we need FFR against the IVAS. So these two technologies are completely different. FFR is basically for physiological assessment and IVAS is for anatomical assessment. So IVAS is highly accurate for vessel sizing, confirming stent expansion, stent deposition in left main plasty, but it does not provide much data about its what is the physiological significance of a stenotic lesion. So where the FFR has a major role. So these two modalities, they are basically contemporary, they cannot replace each other. So why FFR instead of IVAS? We already discussed. IVAS is basically for anatomical mapping and it depends upon a patient's body habitus, and there is a disconnect between the anatomy and physiology if you go by IVAS only. So FFR and IVAS both are totally different. One is for physiological measurement and another is for anatomical measurement. So FFR is preferred to identify whether an intermediate lesion is functionally significant, and IVAS is preferred when assessing the anatomy of a lesion for sizing, positioning of the plaque and adequacy of a stent deployment. So what is the practical clinical utility of FFR in our daily practice? Basically it helps in intermediate lesions when there are multiple serial lesions, osteal lesions, side branch lesions, multivessel disease is there, instant restenosis is there. In these situations, whether when we are in a two mind whether to go for coronary angioplasty or bypass surgery or not, then we have to do FFR, and if the value is less than 0.75, then we are sure that these lesions are significant and we need to do something about it, either coronary angioplasty or bypass surgery. So determining the need for revascularization in disease with intermediate stenosis, FFR is most frequently used to evaluate the functional relevance of a coronary artery stenosis when hemodynamic significance is otherwise uncertain. So up to approximately 2/3 of PCI are performed in the absence of any functional evaluation, and this scenario, often referred to as oculostenotic reflex, is even more worrisome. Now the safety concern have arisen because of late stent thrombosis in the era of drug-eluting stent. So, these are some of the landmark physiological studies with FFR. First, there was a DIFFER study in 2001. Then FAME 1, FAME 2, FAME 3. These are the studies which have shown that FFR guided PCI is superior to angiographically divided PCI. Then another point which I would like to discuss is FFR after myocardial infarction. So in acute phase of MI, myocardial infarction, FFR measurement should not be used due to serious microvascular impairment, and treatment should be guided by clinical symptoms and ECG. Pressure measurements are useful only after the artery has stabilized. So there is no role of FFR measurement in acute coronary syndrome like NSTEMI or ST elevation myocardial infarction because of serious microvascular impairments. So what happened with acute myocardial damage and FFR? There is a ST elevation MI, for example, then there will be a variable degree of reversible microvascular stunning, and maximal achievable flow will not be there. So smaller gradient and high FFR across any given stenosis can occur. So FFR during acute coronary syndrome is not advisable because it will give you a false value, and your treatment would be based on his clinical history, ECG, echo finding only. What happens with chronic microvascular damage and FFR? Suppose we have an old myocardial infarction, there will be irreversible microvascular damage, maximal achievable flow is less, smaller gradient and higher FFR across any given stenosis. So similar stenosis there, but different extent of myocardial perfusion area. So suppose you got normal myocardium, then in that case 4 mm area is too small. And 4 mm area is sufficient for a scarred myocardium. So identical areas but different significance of stenosis can occur because there is a viable myocardium is not there. The total mass of functional myocardium supplied by given stenosis in an infarct related artery will tend to decrease, and thus hyperemic flow and the gradient will both decrease as well. In this case, FFR will increase, reflecting the functional importance of the stenosis that supplies less myocardium. When viable myocardium mass supplied by a certain stenosis decreases, the functional significance of the stenosis decreases accordingly. So you can see when there is a normal myocardium, so 4 mm is not significant because that artery has to supply a larger area of myocardium. And below you can see the same degree of stenosis is sufficient for a damaged myocardium because that artery has to supply less area of myocardium. So FFR in post-stenting, we have deployed the stent, patient is stable. Then is there in place of FFR post-stenting also? So in a large multi-center registry of approximately 750 patients, FFR was obtained after technically successful stenting. A post-PCI FFR value less than 0.9 was still present in almost 1/3 of the patient and was associated with unfavorable clinical outcome. Moreover, post-stenting FFR was the strongest independent predictor of 6-month clinical outcome. So if you get a value of more than 0.9, it's good post-PCI. FFR in bypass graft lesion. There are only a very limited clinical outcome data in patients with bypass graft in whom decision regarding devascularization has been based upon FFR measurement. Although it seems intuitive to use FFR value of 0.75 as a cutoff when assessing bypass graft, this should be done with caution until more clinical outcome data are available. There are certain limitations of FFR also. So there could be hemodynamic artifacts like damped pressure waveform, guide obstruction, contrast media related problems, very small guide when we use less than 5 French guides, pressure signal drift, sidal or ostial pseudostenosis. Technically, there could be loose connection, improper zeroing or calibration problems. Anatomically, when we have extreme tortuosity, inability to wire the lesion or the vessel is in spasm. Sometimes mechanical issues like wire artery impact, and most importantly when we are not able to achieve maximal hyperemia, inadequate hyperemia is there. So these are some of the limitations or pitfalls of FFR. So what are the reasons for a non-significant FFR despite apparently tight stenosis, that is false negative FFR? So some of the physiological explanations are stenosis hemodynamically non-significant despite angiographic appearance, small perfusion territory like old myocardial infarction, little viable tissue is there, small vessel, there are very good collaterals, and severe microvascular disease. These are the physiological explanation for a false negative FFR. Then there may be some problems with interpretations, like there some other culprit lesions might be there, diffuse disease rather than focused stenosis, and chest pain of non-cardiac origin could be one of the reasons. Technical explanation like we are not able to achieve the insufficient maximum hyperemia, or there is some problem with guiding catheter, electrical drift is there, equalization with introducing needle or measurement without it. Then true false negative FFR can be in acute phase of ST segment myocardial infarctions, or in case of severe left ventricular hypertrophy or exercise induced spasm also. So there is a new term like IFR. So IFR is basically you can say similar to FFR, but in IFR, that is instantaneous wave free ratio, we don't need to give any hyperemic agents like adenosine. So it is safe in asthmatic patient. So IFR, that is instantaneous wave free ratio, is by definition is it is instantaneous pressure gradient across a stenosis during the wave free period when resistance is constant and minimized in the cardiac cycle. So in summary, identify a wave free period in cardiac cycle when resistance is naturally stabilized and minimal, and avoiding the need for administration of adenosine. So IFR measured during this wave free period gives a measure of stenosis very similar to FFR. So these are some of the studies in IFR. So in conclusion, FFR strongly supports the concept of functionally complete revascularization, that is stenting of the physiologically significant ischemic stenosis and medical management of the non-ischemic stenosis. In spite of strong evidence favoring its use, FFR is still not used widely. The application of FFR along with angiography combined two gold standard investigation to provide an all-in-one anatomical and physiological assessment of coronary artery disease. Its application in various subset of coronary artery anatomies makes FFR an essential tool in the cath lab in decision making and improving outcome of patients undergoing PCI. So these are the very simple flow chart. So depending upon the clinical presentation, we divide the patient in two groups, whether he is having stable angina or unstable angina or ACS. So if we go in the first arm, that is stable angina, if we see on the coronary angiography there is an intermediate lesion, that is 40 to 70%, then FFR is recommended. You should do FFR to determine the physiological significance of that lesion, and if FFR is less than 0.8, you can go ahead with PCI, and if FFR is more than 0.8, you need to keep the patient on medical therapy. In a severe lesion that is more than 70%, you divide again in two arms, like one arm you keep 70 to 90% stenosis, again FFR is recommended, and again you have to follow the same cutoff, that is 0.8, and if the lesion is more than 90%, then FFR is not recommended. You can go ahead with PCI or coronary angiography bypass surgery if needed. In unstable angina or ACS, if culprit lesion is there, FFR is not recommended because of microvascular changes during acute setting. In non-culprit region, FFR is recommended. Again, the same cutoff has to be followed. So, in angiographically borderline lesions, that is 40 to 90% stenosis in non-ACS lesions, we can do both IFR and FFR also, and the cutoff for IFR is 0.9. Thank you.